Good morning. Sorry for being late by 7 minutes for net issues. Today we'll have a presentation on hiatal anatomy and management of gastric reflux disease. So if you go to the esophageal hiatus in the diaphragm, we should be knowing the basic diaphragmatic anatomy, where diaphragm has got a central tendon and a peripheral muscular part. And this peripheral muscular part is divided into anterior sternal part, costal part, and posterior part, the two crura and the lumbocostal arches and the median arcuate ligament. So this is a overview of the diaphragm, where you find the central tendon in the center, and you find the muscular part, which is costal, sternal, and the posterior, which is arising from the vertebral bodies. And these two crusts are important for the hiatal anatomy. And these two crusts are the right crust and the left crust, which has got a tendinous origin. The left crust is coming at a lower level, and the two crusts meets, and this two crura is forming the esophageal hiatus, through which the esophagus comes to the abdomen. Apart from these, there are some ligaments we come across, and these ligaments are the median arcuate formed by the fusion of two crura, through which the esophagus is coming down to the abdomen. And then apart from these, there are medial lumbocostal arch and the lateral lumbocostal arch. If you come to the esophageal anatomy, esophagus is a 25 centimeter long muscular tube which extends from the pharyngeal junction to the stomach. It starts at 6 cervical vertebra and ends at the level of 11-12 thoracic vertebra. Esophagus has three parts. It's described as cervical, thoracic, and abdominal part. It deviates to the left in the neck, to the right in the thorax, and then it goes to the left in the abdomen. And there are two defined esophageal sphincters. One is described as upper esophageal sphincters, which is at the pharyngoesophageal junction. And in relation to the gastric reflux disease, the lower esophageal sphincter is important. And lower esophageal sphincter is the junction between the esophagus and the stomach. Classically described as esophageal junction. This normal anatomy, these sphincters prevents reflux. And if you go endoscopically, you will find a clear Z line, which is the junction of squamous lining of esophagus and the columnar lining of the stomach, the junction of pale and pink mucosa. The longitudinal folds of the esophagus blends with the longitudinal folds of the stomach. So what are the normal mechanisms which prevents gastroesophageal reflux? There are some normal anti-reflux barrier, like the lower esophageal sphincter. The angle of His is the junction between the cardiac end of the stomach and the esophagus. The crural diaphragm, which forms the esophageal hiatus, plays some role in preventing the reflux. The phrenoesophageal ligament is another important structure which also helps in prevention of the reflux. And the esophageal mucosal resistance, which is lined by the squamous cells, provides some resistance against the acid reflux. So what is gastric reflux disease? The most common upper GI disorder. It's characterized by heartburn and/or acid regurgitation. The incidence is very high in the Western world, to as high as 10 to 20%, but it is observed that this GERD is less common in Asian population, which is about less than 5%. So what happens in GERD? The reflux of gastric contents into the esophagus because of incompetence of esophageal junction. The lower esophageal sphincter becomes hypotensive as it is not contracting properly. And depending on the mucosal injury in the esophagus, GERD is classified as it can be an erosive reflux disease when there is mucosal injury in the esophagus, or in spite of acid reflux, there is no erosion or mucosal injury in the esophagus, described as NERD, non-erosive reflux disease. And one complication of this reflux is Barrett's esophagus. So there may be changes in the squamous lining of the esophagus from squamous to the columnar lining. There is another entity called as reflux hypersensitivity. It's characterized by retrosternal symptoms like heartburn, chest pain. Patient has to be symptom for about 3 months with a frequency of twice per week. However, no abnormally increased reflux is seen in these conditions. 24 hours acid monitoring by pH study or pH impedance shows normal acid exposure in the lower esophagus. There is no structural changes, no evidence of motility disorder. These patients may respond to acid suppressive therapy. So these are not classically a reflux disease, but described as classically as reflux hypersensitivity. There is another term called functional heartburn. Here the patient who complains of rectal burning or discomfort may complain of chest pain. This patient often remains refractory to acid suppressive therapy. And on endoscopy or by pH monitoring, there is no evidence of GERD in these patients. So, gastric reflux disease may be manifested by various symptoms. This can be either described as a classic typical symptoms, there may be some atypical symptoms, or there can be some extraesophageal symptoms. High specificity for GERD are acid retention and heartburn. Based on the presumptive diagnosis, patient presenting with heartburn and acid retention, one can start on empiric therapy without going for further investigations. Further diagnostic stage is needed to confirm the diagnosis of GERD or if you suspect complications of GERD. So, how is the diagnosis of GERD made? This can be made either by the classic clinical symptoms or atypical symptoms. This diagnosis can be empirically made by response of these symptoms by anti-secretory drugs. Next is endoscopy and reflux monitoring. So there are some limitations in the diagnosis of GERD. You may find endoscopic evidence of GERD in the form of esophagitis or Barrett's esophagus, but patient may have no symptoms. Patient may have symptoms of acid retention or heartburn, but on endoscopy, there is no evidence of reflux disease. So it can be a situation of reflux hypersensitivity syndrome or functional heartburn. So what are the classic and atypical symptoms in GERD? There may be a wide range of symptoms. The typical symptoms which has got high sensitivity specificity are heartburn and acidity. Patient complains of acid retention in the mouth more after meals aggravated by lying down. Atypical symptoms may be epigastric pain, dyspepsia, nausea, bloating, and belching. There may be some extraphysical symptoms like chronic cough, asthma, wheezing, hoarseness, sore throat, laryngitis, and dental erosions. The pulmonary symptoms in reflux is explained by microaspiration of the refluxant, or there is shared vagal innervation of the cough reflex and the esophagus, described as esophageal reflex. So, extraesophageal symptoms are situations where you need to have some investigation to confirm the diagnosis before starting empiric therapy to exclude other diseases. So, the most important symptom for diagnosis of GERD is heartburn and acid retention. And based on this presumptive diagnosis, one can start on empiric PPI therapy. So what is empiric PPI therapy? This is a 2-week trial of PPI therapy on standard dose. Patient who has got classic symptoms may respond to PPI therapy, and that may give a indirect evidence of diagnosis of GERD. However, PPI therapy is not very effective in patients who have atypical symptoms. Some patients of reflux hypersensitivity may also respond to PPI therapy and sometimes may lead to overdiagnosis of GERD. If patient responds well to PPI therapy, presumptive diagnosis of GERD is. So what are the indications for doing further testing in patient of GERD? If the patient has got some alarm symptoms like dysphagia or dynophagia or weight loss, typical symptoms, but patient are not responding to PPI therapy. Further evaluation for diagnosis of GERD or excluding an alternate diagnosis. The disease is persisting for an extended period of time in spite of PPI therapy. If there is a concern for complications like Barrett's esophagus, atypical symptoms or non-cardiac chest pain needs further diagnostic test prior to empiric therapy. So, how upper GI endoscopy helps? Evaluation of the esophagus mucosa is important for patient having reflux disease, and if the patient has got strictures or Barrett's esophagus or any mass lesion esophagus, that needs to be biopsied. However, a normal endoscopy does not refute the diagnosis of gastric reflux disease. So, upper GI endoscopy is mostly performed for evaluation of GERD associated complications for any alternative diagnosis. And for one of the evaluation for this reflux disease is pH monitoring. And upper GI endoscopy will be used to place sorry, wall-less capsule into the esophagus. Patients with risk factors for esophageal adenocarcinoma need to be evaluated by upper GI endoscopy. Another important mode for diagnosis of reflux disease is esophageal pH monitoring. This can be either a esophageal pH monitoring or it can be impedance pH monitoring. It's only test to confirm presence of acid reflux. And this can give a diagnosis of reflux frequency and association between symptoms and reflux episodes. This is required for preoperative evaluation for non-invasive disease. In non-invasive disease, there is no endoscopic evidence of reflux. Only pH monitoring will give a diagnosis that there is positive acid reflux. So these are the patient who has got persistent symptoms despite medical therapy and no endoscopic evidence of GERD needs to be assessed by esophageal pH monitoring. This impedance pH is measured by placing some electrodes mounted on a thin intraluminal probe and placed in the esophagus just 7 centimeters proximal to the Z line. What is the role of barium esophagogram? Barium esophagogram is not diagnostic of gastric reflux disease. This is indicated in situations where the patient has got dysphagia. Otherwise, apart from dysphagia, when the patient may have peptic stricture, for diagnosis, you can do a barium esophagogram. Otherwise, barium esophagogram is not recommended for diagnosis of GERD. So how one can do reflux monitoring? This reflux monitoring can be done by using a wireless capsule or a transnasal catheter. It is either measurement of pH alone or combined pH impedance. Patient may be either on or off acid suppression. For either study, diet and activity should be remain unchanged. And this reflux monitoring capture an accurate depiction of day-to-day esophageal acid exposure. So how we do a wireless capsule monitoring? This is a capsule which is placed inside the esophagus, and this records the pH in the esophagus, and it is sent to a transducer placed in the patient abdomen outside. The capsule is placed 6 cm above the squamous junction, and this measures the pH and transmits the data via radiofrequency signal to a small receiver clipped onto the patient's belt. So what are the advantages of wireless capsule monitoring? This gives the patient less discomfort, allows for recording time maybe beyond 24 hours, improve accuracy by allowing the patient to resume normal activities, no need for a transnasal catheter, and position of capsule is not altered by swelling. Disadvantages needs an endoscopic procedure, early detachment in some patients, and this may sometimes lead to overdiagnosis due to ingestion of acidic food. This can be measured also by placement of a transnasal catheter. Catheter is placed in esophagus transnasally, and impedance pH monitoring is possible. This allows distinguishing between acid and non-acid or weak acid reflux in gastric reflux disease. Impedance monitoring also allows to differentiate the antegrade and retrograde bolus transit of both liquids and gas. So sometimes if you take acidic food, pH monitoring may be faulty. So this can differentiate a antegrade acid coming down to the esophagus or a reflux from the stomach. Esophageal manometry is not recommended for diagnosis of GERD, but once you have planned for management of GERD in the form of some reflux, anti-reflux procedure, one need to do a esophageal manometry because this manometry study will diagnose any underlying esophageal motility disorder like achalasia or scleroderma. So this has to be done prior to anti-reflux surgery to rule out esophageal dysmotility. What are the complications of gastric reflux disease? In view of acid reflux, it can cause erosive esophagitis. It can lead to ulceration and ultimately peptic stricture. This acid reflux in the esophagus can cause columnar metaplasia, leading to Barrett's esophagus. Subsequently, if the Barrett's esophagus has got dysplasia, which progress from mild to moderate to severe dysplasia and ultimately can go to esophageal adenocarcinoma. This can cause a pulmonary disease. These esophageal symptoms are the result of GERD. So how to manage reflux disease? This GERD is very common in Western countries, and this has got tremendous impact on health and quality of life. Persistent reflux symptoms on PPI therapy, patient has reduced physical and mental health and quality of life. So this is an important disease which has a social impact in the form of cost for the patient and to the society also. So GERD is a chronic disease. This requires long-term management. The components for management of GERD includes lifestyle modification, medical therapy with acid suppression, and surgical therapy with anti-reflux surgery, and another important part is endoscopic therapy. So what are the lifestyle modifications? Obese patient has more incidence of reflux disease. So weight loss is very important for preventing the reflux disease. Elevation of the head on the bed and avoidance of recumbency within 3 hours after meals. And sometimes patient has got severe nighttime symptoms, may avoid nighttime meals. And there are some trigger foods which accelerates GERD, like chocolate, caffeine, and alcohol. And these lifestyle changes may result in improvement of symptoms in some patients, but most of the patients will require some form of medical therapy. So what is the medical therapy for GERD? The mainstay of treatment of GERD is acid suppression. And this acid suppression may be achieved with antacids, ACE receptor antagonists, or proton pump inhibitors. But one is to consider that proton pump inhibitors are costlier than the antacids and ACE receptor blockers. And PPI is to be taken 30 to 60 minutes prior to meals. However, the newer PPI like lansoprazole can be taken irrespective of food intake. And once the patient responds to this PPI therapy or acid suppressive therapy, then these are the patient who need to be followed up. And some patient may require some maintenance or step-down therapy. Patient having non-erosive reflux disease, after initial response, may stop PPI, and if they're symptomatic, they can use on-demand PPI or hysterectomy block. However, some patient with reflux disease may require a maintenance therapy with PPI. Most of the patients who respond initially to the PPI therapy remain asymptomatic on step-down therapy or no therapy at all. One has to consider the high cost associated with indefinite PPI use. If symptoms recur, then maintenance PPI therapy should be reconsidered. What is recurrent gastric reflux disease? If the patient has got a course of 4 to 8 weeks of PPI therapy, and then after stopping therapy, if the patient has got recurrence of symptoms, we stamp that patient as recurrent GERD, and these are the patients who require additional therapy. It has been observed that shorter dinner to bedtime interval is the most significant factor for recurrence of GERD. So patient who usually slept within 3 hours after eating had higher recurrence rates. What is PPI refractory GERD? If the patient has got persistent symptoms in spite of empirical PPI therapy, we refer that patient as PPI refractory GERD. So that patient should be evaluated by a gastroenterologist. And the first thing to assess of this patient is to inquire from history whether the patient is compliant, whether he is taking the proper dose and the proper PPI therapy. A large study has revealed the patient with GERD does not comply with their PPI therapy. Only in 66 and 60% of these patients, they are compliant for their prescription. So a current history is important. If the patient is not compliant, there is no reason to escalate therapy. You have to ensure that patient is taking the usual drug. In truly refractory cases, either you need increased dose of PPI or need to use an alternate PPI. And if the patient has got symptomatic improvement in escalating therapy, then you continue with the escalating dose of PPI. Patient having predominantly nighttime symptoms, you can increase the dose of PPI to BID or nighttime dosing of PPI. Or you can add a nighttime dose of H2 antagonist and a BID PPI therapy. However, it is observed that if you use H2 receptor antagonist therapy, this therapy is not effective after 1 month, and it is observed that gastric acidity returns to pre-H2R level after 1 month of H2 receptor antagonist therapy. Another important drug which has been shown to be effective against GERD is the baclofen. This baclofen inhibits lower esophageal sphincter relaxation. It reduces postprandial reflux and acid exposure by inhibiting transient LES relaxations. So, administering baclofen at bedtime decreases sleep-related reflux events. So, baclofen is indicated in patients with persistent symptoms and PPI therapy, patient having persistent nighttime heartburn and sleep complaints. However, baclofen has got important side effects like drowsiness, dizziness, weakness, and fatigues. So, side effects of baclofen precludes long-term use of baclofen. We are in the habit of using a lot of prokinetics, but it is observed that there is no clear role of prokinetics in treatment of GERD. So, how do you assess patients who are symptomatic even after maximal medical therapy? These are the patients who needs evaluation for non-GERD etiologies. These are the patient who needs upper GI endoscopy to exclude other diseases like esophagitis or Barrett's esophagus. If you do upper GI endoscopy and find esophagitis, and that is because of GERD, this may be either because of non-compliance of therapy or failure of medical therapy. Upper GI endoscopy with pH monitoring confirms the diagnosis or refute the diagnosis of GERD. Acid reflux plus symptom correlation may indicate PPI failure. So, consider escalation of medical therapy if there is poor compliance. So, this PPI therapy is not without side effects. Long-term PPI therapy has been shown to cause an increase in some Clostridium difficile infection. Patient may have increase in some bone fractures, hypomagnesemia, or patient may have higher incidence of chronic kidney disease. So, what are the next option? If the patient is on medical therapy and not responding, or patient does not want to continue medical therapy for a prolonged period of time, surgical therapy is another option for treatment of gastric reflux disease. And the introduction of laparoscopic surgery has opened a avenue for minimal invasive treatment for GERD, and now regarded as the gold standard treatment for GERD. So, what are the indications for anti-reflux surgery? Patients are unwilling to remain on lifelong medical therapy. There is intolerance of medical therapy. Patient has refractory symptoms in spite of adequate medical therapy. Patient has developed complications of GERD like Barrett's esophagus and peptic stricture. GERD in the setting of a large hiatal hernia. If the patient has got a large hiatal hernia, there is no reason that this patient respond only to medical therapy. This patient will need crural repair and an adequate anti-reflux procedure. Patient having atypical symptoms like asthma, hoarseness, cough, chest pain may respond to anti-reflux surgery. So, patient having medically refractory GERD, the setting of morbid obesity, needs early surgical treatment. So, what are the preoperative workup for patient who have to undergo anti-reflux surgery? Upper GI endoscopy, esophageal pH monitoring to document the reflux disease, and as I said earlier, that patient should have a esophageal manometry to ensure that there is normal esophageal motility. So, what are the important surgical aspect of reflux disease? This surgical treatment is not a cure in all cases. So, one has to be very critical about selecting patients for GERD for surgical management. Highest surgical response occurs in patient who has got typical symptoms. Highest surgical response occurs in patient who respond well to PPI and patient having abnormal pH testing report with a positive report of acid reflux. So, patient may have improvement or resolution of heartburn, regurgitation, dysphagia when compared before surgery. So, surgery for GERD, laparoscopy versus open technique for GERD. It was earlier an open surgery for reflux disease, but with the advent of laparoscopy, it has been observed that laparoscopic surgery is a situation where the patient has got shorter hospital stay, less pain, less wound complication, early return to work. And these are the patients who respond well to laparoscopic anti-reflux surgery. And some patients who has got a revisional surgery being required for anti-reflux surgery, though the patient who are earlier offered an open abdominal approach, now also being managed laparoscopically. So long-term results has support the use of laparoscopic fundoplication as a gold standard for GERD. Regardless of the type of fundoplication, aim of the operation for anti-reflux surgery is recreate and restore the normal physiologic functioning of lower ischial sphincter. Reconstruct the hiatus if you have associated hiatal hernia, and if the hiatal hernia is there, you have to repair the hiatal hernia. So there are different ways we can do the anti-reflux surgery. One is a classic Nissen fundoplication, where you need to mobilize the greater curvature. You mobilize the medial side of the esophagus, and you wrap the lower esophagus to the extent of about 3 centimeter, and this is a 360-degree turn. You do the anti-reflux procedure. In view of higher incidence of dysphagia following recent fundoplication, the modification came as 2-pay or 270-degree fundoplication, where you turn the stomach around the lower esophagus and don't do a 360. You suture the stomach to the side of the esophagus with the extent of 270 degree. Another important modification for this is door fundoplication. Sometimes it is difficult to do a posterior fundoplication. In that case, you can turn the stomach fundus towards the anterior side and suture it for about 3 centimeters abdominal esophagus. This is described as door fundoplication. So these are the different varieties of fundoplication, where you can do a 360-degree fundoplication, Nissen, 2-pay, or door fundoplication. And this is a short overview of the advantage and disadvantage of different types of fundoplication. Nissen fundoplication is very effective in controlling reflux over long periods of time. However, if the wrap is tight, patient may have increased flatulence, bloating, and dysphagia. Door fundoplication may cause less posterior dysphagia, but these are the patient who may have a recurrence of symptoms over time requiring more reoperations. 2-pay fundoplication, these are patients who has less posterior dysphagia, but assessment for the length of wrap is important as it determines the quality of reflux control. Again, this robotic surgery has come up as part of GERD management, and like laparoscopy procedure, robotic surgery is viable and safe option for doing the reflux procedure. And same procedure like Nissen, door, or 2-pay fundoplication may be done with using robots. And the advantage of robotic fundoplication is you have got improved ergonomics, visualization is better with a 3D picture, comfort, and autonomy. However, disadvantage of robotic surgery is a longer surgical time, longer learning curve, and generally higher cost than laparoscopic. So what are the indications for revisional surgery following anti-reflux procedure? The failure rate of fundoplication ranges from 3 to 16%. Not every patient who has failed anti-reflux surgery needs reoperation. Most common indications for reoperations are a slipped fundoplication or herniation from the wrap into the mediastinum. Laparoscopic reoperative anti-reflux surgery is a viable and safe option. Although effective, reoperative surgery has got higher complications rate, longer operating times, and higher conversion rates. However, patient satisfaction after revision surgery is generally high. There is a resolution of heartburn and symptoms to the extent of 80%, resolution of regional trouble 85%. So what are the outcome of fundoplication? The short and medium term outcome of laparoscopic anti-reflux surgery is quite good. In the long term, these results of medical and surgery, we observe that 6 anti-reflux procedure needs some medications compared to 92% of medical patient who needs to continue the medical treatment. So anti-reflux surgery is effective, but these are the patient who also may need some anti-secretory medications. So what are the complications of anti-reflux surgery? It can be dysphagia if not a properly done wrap, significant increase in flatulence and inability to belch, gas bloat syndrome. In view of complications, careful selection of patients are important for anti-reflux surgery. A newer addition to the GERD surgery is a sphincter augmentation by using the LINX reflux management system. This surgery
Sphincter
involves
augmentation. হ্যাঁ ওইটা একটা হ্যাঁ ওইটা একটা আর এইটা করতে হবে
Non participants, please mute yourself.
তাহলে তো একটা মরবি আরেকটা কি করবে অনগোয়িং মরবিডিটি কিছু লিখতে হবে এটা তাহলে
Dr.
নেক্সট মান্থ ডিসকাস তো হয়নি পেশেন্ট হ্যাঁ ওর আন্ডারে হয়ে যাবে এটা ওকে অনেক ডিটেলসে
Dr.
লিখতে হবে
Shitama, you are unmuted.
ও আরেকটা মরবিডিটি অ্যাড হবে তাহলে জয়সরের 1007
Shitama, you mute yourself. So, what is the surgery? This surgery involves placement of a bracelet of titanium beads with magnetic cores around the lower esophageal sphincters. So, this augments the physiological barrier to reflux without altering gastric anatomy. And following this LINX implantation, 87.5% patients are satisfied, and 80% patients are free from daily dependence on PPI. Now comes the endoscopic management of GERD. There has been a lot of endoscopic procedures, and some has been gone off. And the major reason for endoscopic management was patients who are failing with endoscopic medical therapy and going for a reflux surgery. A bridge was required to see whether the patient can be benefited by some endoscopic procedures. So there are different endoscopic procedures being tried in patients with GERD, like radiofrequency ablation, endoscopic fundoplication devices. Current endoscopic devices has got much improvement. However, this endoscopic procedure is less impressive and there is poor response to the reflux. So this are the patient selected for endoscopic treatment are the patient who has got response to PPI or not responding to PPI, but not willing for anti-reflux surgery. So they are the patients who are offered minimal invasive treatment in the form of endoscopic treatment. However, most of these did not stood the test of time. The various endoscopic treatment includes enterics, gatekeeper, plexiglass microsphere, several endoscopic apposition devices, endocleage, and plicators. So I'll discuss a few of these. So what are the options for endoscopic management of GERD? This can be a radiofrequency ablation in the form of described as strata. It can be transoral fundoplication using esophagus, Muse, or GERD, or it can be mucosal resection described as anti-reflux mucosectomy. So what is radiofrequency ablation? It's a system called strata. You apply radiofrequency energy via a needle balloon catheter to the lower esophageal sphincter muscle and gastric cardia. Multiple applications are made by changing the position of the balloon catheter in relation to the Z line. The system typically delivers very low power, 5 volts of energy. Abundance of high temperature is required in the muscularis and the mucosa to avoid injury. Regular irrigation prevents any injury to the mucosa. So this is the radiofrequency. You place this radiofrequency probe in the lower esophagus, in the region of sphincter, and use low heat wave in this area and rotate the balloon to burn the local area. This allows the lower esophageal sphincter to act better. Then comes the endoscopic fundoplication. The most common procedure being performed now is described as transoral incisionless fundoplication, TIF. Only a subgroup of patients experienced improved quality of life and reduced need for PPI at 3 years of follow-up. There is unacceptably high percentage of patients required additional medication or revisional laparoscopic fundoplication following endoscopic procedure. So how does this transoral fundoplication helps? The endoscopic treatment for GERD, and this follows the principle of anti-reflux surgery. This can help in reducing a small hiatal hernia, which is less than 2 centimeters. It can create a valve 2 to 4 centimeters length, and it can provide a circumferential wrap more than 270 degrees. It can be performed in the outpatient setting under general anesthesia. So this is the procedure. I'm not going into details. This procedure is using a specialized endoscope which can bend itself, and this endoscope is placed in the stomach area and it is bent forward. And by pulling the mucosa, this can stipple this. So you can have a wrap. You can have a wrap around the esophagus by this endoscopic procedure, described as transoral incisionless fundoplication. This durability of the response is emitted in a recent study with a 6-year follow-up. PPI were stopped or halved in 87.8 and 84.4% at 2 and 3 years, with stable response up to 6 years. One study compared TIF with anti-reflux surgery, Nissen 2-pay fundoplication. Both groups showed similar reduction in symptom frequency and severity. However, patients undergoing TIF exhibited significantly shorter operative times and length of stay. So this TIF is now coming as a popular endoscopic procedure for reflux disease. There is another important innovation for this reflux disease endoscopy is described as endostapler, described as Muse. This is an endostapler where this instrument inside the esophageal junction can staple part of the stomach to the esophagus, creating a anti-reflux mechanism. This is the endoscope where you have this anvil with the staple, and on introduction, this can cause stapling of the part of the stomach to the esophagus side, creating a anti-reflux. Apart from this, there are other endoscopic innovations like endoscopic full thickness plication. However, this device is no longer available commercially. These are the plication which can be done endoscopically. Another important innovation for endoscopic management of reflux is the anti-reflux mucosectomy, where you introduce the endoscope inside the esophageal junction and do circumferential mucosectomy. And this mucosectomy allows fibrosis in this area and cause reduction of reflux symptoms. This is the endoscope where you do a circumferential mucosectomy around the esophageal junction. In this, there is no endoprothesis left in situ, and it is a claim that results are comparable with other procedures. What is the management of GERD in obese patient? Patient who has got morbid obesity with a BMI of 35 kg per square meter, there is higher failure rates following Nissen fundoplication. It is observed patients are these are the patients who have got durable response of GERD. So additional effects of Roux-en-Y gastric bypass is reducing the obesity comorbidities, reduce the long-term mortality risk of morbid obese patient. So Roux-en-Y gastric bypass superior to adjustable gastric banding and slim gastrectomy for reflux disease. So PPI are the cornerstone or medical management of GERD. This endoscopic treatment are not meant to replace PPI altogether. This endoscopic management may breach the unmet gap between the PPI and anti-reflux surgery. However, more studies with long-term follow-up and randomized comparisons are required to establish the role of endoscopic management of anti-reflux surgery. So in conclusion, GERD is a common disorder. It's more prevalent in the Western countries than the Asian population. They've got varied modes of presentation like typical, atypical, and esophageal symptoms. Complication of GERD includes erosive esophagitis, Barrett's esophagus, stricture, and adenocarcinoma. Presumptive therapy with PPI is a cornerstone for management of GERD because all cases will not go for endoscopic assessment. Patients who are responding to PPI will need step-down therapy and maintenance therapy. PPI refractory cases needs proper evaluation. Endoscopic therapy is helpful in selected cases, and careful selection of patient for endoscopic therapy may offer them anti-reflux procedure without surgery. Surgical intervention in those who fail medical therapy, are non-compliant, or wish to discontinue long-term medical therapy, have complications secondary to GERD, or present esophageal symptoms. Various types of anti-reflux operations that have been quite successfully treating GERD is the gold standard. However, all patients for esophageal surgery needs proper evaluation and counseling, as most of the patients may require some form of anti-secretory medications even after surgery. Patient situation like morbid obesity and revisional anti procedure needs more critical evaluation. Thank you. Any question? This is a important long question for both MS and DNB examination, because GRD is a important theory question. So you need not go into such details. You just put outline. If you are answering for the theory exam, you can just put an outline. What is GRD? What is the complications of GRD? What are the presentation like typical, atypical symptoms, investigation for GRD? So a empirical PPI therapy is also an investigation. If the patient respond to PPI therapy, these are the presumptive diagnosis of GRD. And then management, you just give the outline. All details are not required. Anything in the chat box?